Hello, everyone. This is Dr. Mickey recording a lecture on medication or drugs for the control of pain. These medications or the list of meds that we have or the classifications of meds in this chapter, chapter 18 will be for pain management. So first of all, we'll talk about the pathophysiology of pain. So first of all, the psychological factors can increase or decrease perception of pain. Because patient, when they experience pain, they experience two main components of pain. Pathophysiology, which is the physiologic effect, and the psychological experience. So the psychological factors, such as like anxiety, it increases, it potentiates perception of pain. However, on the other side, the positive attitude, social support, would decrease person's perception of pain. So the effective pharmacology of pain management, as we treat patients for pain experiences, the pain management should include or depend on the assessment of pain, degree of pain. So we have assessment of pain and to determine the underlying disorders of pain. So knowing that pain is, it's a migraine headache and it's caused by certain conditions, or is it like phantom pain because it's that status post amputation of a limb, or it's chronic pain, is it acute, is it post-surgical intervention? So the effective pharmacotherapy depends on the assessment of degree of pain and determining the underlying disorders. So what is pain, or what is the definition of pain? Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So we always have, we have to manage pain based on the patient's disclosure and patient's description of their pain experiences. So pain, whatever the experiencing person says it is existing whenever he or she says it does. So which means that we always have to believe the patient, and we always have to treat pain as being disclosed and described by the patient, who is the one who is experiencing that pain experience. So the pain experience or the experience of pain, there are three systems that may interact to produce this type of pain experience. So it's three systems, they interact with each other, and then eventually we will have this, what is called, patients experiencing mild, moderate, or severe pain. So the sensory discriminative system, in which it's to process, this system processes the information about the strength, the intensity, the temporal, the spatial space, all these aspects of pain, intensity, and strength, and so forth. And this usually, this sensory discriminative system, which processes this intensity and strength of pain, it's mediated through the afferent nerve fibers, the brainstem, spinal cord, and result in immediate withdrawal of the painful stimuli or painful stimulus. The second system, which is the motivational affective system, which determines the individual's conditioned or learned approach. In other words, avoidance behavior. Responsible for this in the nervous system is the reticular formation, the limbic system, the brain stem. They're all responsible for this motivational affective system. And the third system that will interact with the previous two to produce pain experience is the cognitive evaluative system. And it's through the learned, these are the experiences or pain experience in which that the certain factors affect this specific, how we build our tolerance to pain and how we try even attempt to manage pain experience. So it's through individuals' learned behavior concerning the experience of pain, like learned through the cultural preferences, gender roles as being socialized during the socialization process as during the childhood, life experiences, people who live with chronic diseases and they tend to experience more pain experiences, their tolerance to pain usually it's higher than others who do not live the same experiences. So these are learned through the cultural preferences, gender roles, life experiences, and the cognitive evaluative system. It may block, modulate, or enhance the perception of pain. There are other theories that will explain pain experience, but we will focus on certain theories, like the two most important ones are the gate control theory. That's one of the oldest theories that explains the pain experience, and the neuromatrix theory. But there are other theories like the specificity theory. So what is, and the pattern, and the other one is the pattern theory. So let's focus on these two main theories that will explain pain experience. First one is gate control theory. So the gate control theory developed to explain the complexities of pain phenomenon, but this theory was inadequate. In other words, that this theory was unable to explain chronic pain and phantom limb pain. So this theory lacks the explanation. That's why it was inadequate to explain chronic pain and the phantom limb pain. So pain transmission is modulated by the balance of impulses transmitted to the spinal cord by large A, delta, and small C fibers, which terminate on inhibitory neurons in the substantia gelatinosa. Now, cells in the substantia gelatinosa, they function as a gate by regulating the transmission of impulses to the central nervous system. So the gate control theory, stimulation of the non-nociceptive large A delta fibers, such as touch, vibration, or thermal stimulation, causes the cells in the substantia gelatinosa to close the gate, which diminishes pain perception. So closure of that gate at the substantia gelatinosa, it will diminish the pain perception. An example of that will be rubbing the pinched finger. It can reduce pain. As we rub the pinched finger, sometimes it will, it does reduce pain because you attempt to close that gate, which is at the substantia gelatinosa. Small C fiber input inhibits cell in the substantia gelatinosa and opens the gate. In other words, it will enhance pain perception. These small C fibers. They will inhibit the cells in the substantia gelatinosa and will open the gate, which in other words will enhance pain perception. The neuromatrix theory, which represents the plasticity of the brain and provide a holistic, integrated, dynamic view of pain experience. It's more robust, more comprehensive, more in-depth, it covers more explanations about how patients, when they experience pain due to like phantom pain or chronic pain, that this theory provides more explanation. So when there is no discernible cause or specific identifiable cause for chronic pain, such as like phantom pain, neuropathy, sometimes patients will like vascular or due to diabetes, they develop the neuropathic pain, or after the amputation, they develop what's called the phantom pain. So when there is no specific causes or identifiable cause for the chronic pain, like these phantom or neuropathies, the brain produces patterns of nerve impulses from a widely distributed neural network with multidimensional input, including genetic, affective, cognitive, evaluative, and other components. So this theory, which is theory, includes all other aspects of genetic, affective, cognitive, evaluative. So all these factors would interact with each other to produce more explanation about the pain experience. So that's the neuromatrix theory. So the neuroanatomy of pain, the portion of the nervous system responsible for the sensation and perception of pain can be divided into three different areas: the afferent pathways, the interpretive pathways, and the efferent pathways. So the processing of potentially harmful or noxious stimuli through the a normally functioning nervous system is called nociception. So when there is a noxious, harmful stimuli, that process which leads to the perception of pain is called nociception. And nociception involves the four phases towards the production of this pain experience: transduction, transmission, perception, and modulation. The pain transduction begins when a tissue is damaged by exposure to a chemical, mechanical, or thermal noxious stimuli, harmful stimuli, chemical, mechanical, thermal. So when these tissues are exposed and most of the time damaged by these stimuli, this causes activation of nociceptors, which are free nerve endings in the afferent peripheral nervous system that will selectively respond to different types of stimuli. These nociceptors are located throughout the body, but they are not evenly distributed, so the relative sensitivity to pain differs according to their location. The pain transmission, which is the conduction of pain impulses along the A delta and C fibers into the dorsal horn of the spinal cord. So the spinal cord receives pain impulse through the first alpha, A, sorry, A delta fibers and the C fibers. So two different fibers in which that the spinal cord will receive the pain impulse through A delta fibers and the C fibers. The A delta fibers believe to signal sharp, well-defined pain, and then the C fibers believe to conduct or result in dull, poorly localized pain. Now, the activation of the nociceptors causes the ion channels, sodium and calcium, to open. That's from the activation of the nociceptors. It will result that these ion channels like sodium and calcium channels to open, and then that will create the electrical impulse that travel through two primary types of nociceptors. So opening these channels, the sodium and calcium channels, activating these receptors will result in opening these two channels, and it will create electrical impulse that will travel through the primary types of nociceptors, the A delta and C fibers. Now, the medium-sized, thin myelinated A delta fibers. So the A delta fibers they have a myelin sheath. They are covered with myelin sheath. They're thin, medium-sized but thin. Now they are rapidly transmit sharp, well-defined, fast pain sensations. However, the other C fibers, which is the smaller, they don't have any myelin sheath, so they are unmyelinated. There's no myelin sheath that would cover the C fibers. They slowly transmit dull, aching or burning sensations, and they are poorly localized and often constant. So which one is responsible? Which fiber is responsible for the reflex withdrawal of the affected body part from the stimulus before the pain sensation is perceived? The A delta fibers. These A delta fibers, they are responsible for causing the reflex withdrawal of the affected body part from the stimulus before pain sensation is perceived. So nociception, which is the sensory process leading to the perception of pain. That's called nociception. What are the nociceptors? There are free nerve endings in skin, muscle, joints, arteries, viscera, which is internal organs, that respond to different stimuli, chemical, mechanical, thermal stimuli. So nociceptors, they can detect a wide range of stimulus or wide range of stimuli. A delta fibers or C delta fibers. So again, just recapping that, the A delta and the C fibers. The A delta fibers, we said it's covered with myelin sheath. There are afferent neurons, transmit pain more quickly, and they can carry well-localized, sharp pain sensations. However, the C fibers, which does not have any myelin sheath covers, so they are unmyelinated C fibers. They are afferent neurons. They have slow pain transmission and poorly localized pain, diffuse burning or aching sensations. And this slide shows the two divisions of the spinothalamic tract carry pain information to the brain. So we have the lateral and the medial tract. Lateral neospinothalamic tract, which transmits the acute pain and or carry acute pain experiences and then information. And then the medial paleo-spinothalamic tract, which will carry pain information or to the brain of the dull, burning pain sensation. The neuromodulators located in pathways that will mediate information about painful stimuli throughout the nervous system, and it's triggered by tissue injury and chronic inflammatory lesions. Now, the tissue injury like prostaglandin, bradykinin, will be released with that tissue injury, and that will result in pain sensation or experience due to the release of that prostaglandin and the bradykinin. Chronic inflammatory lesions will result in the lymphokines, and these lymphokines will trigger that pain sensation or experience. So we have two different neuromodulation. Either it's an excitation of the system or inhibition of the system. So first of all endorphins attach to opiate receptors on the plasma membrane of the afferent neuron, and the combination will inhibit the release of excitatory neurotransmitters. In other words, that the endorphins, either it's intrinsic natural endorphins, or we usually receive the opioid medications to alleviate pain, but these are the intrinsic endorphins, in which that also the synthetic opiates will attach to the opiate receptors, same thing. So the endorphins or the opiate as a medication, it will attach to the opiate receptors on the plasma membrane of the afferent neuron, and that combination is going to result in inhibition of the release of the excitatory neurotransmitters. So the excitatory neuromodulation, like substance P, glutamate, somatostatin, these are the source of pain experience. So the excitatory neuromodulation result or leads to pain. So substance P, glutamate, somatostatin, the release of these chemicals or neurotransmitters result in pain experience. However, the inhibitory neuromodulation, like the GABA, glycine, serotonin, norepinephrine, endorphins, the release of these neurotransmitters will result in a pain alleviation. It will alleviate pain experience. Now, the pain threshold, pain tolerance, and what's the difference between them? First of all, before we get to the difference, we have endorphins. So we said we have endogenous endorphins, or we can call them endogenous intrinsic morphines. Like our body produce these morphines or endorphins. So it will inhibit the transmission of pain impulses by binding or blocking to the mu, kappa, or delta opioid receptors. So once these endorphins or these opioids or these morphines, the Here we're talking about the endorphins as an intrinsic, natural, endogenous morphines. It will inhibit the transmission of pain impulse by binding to these receptors, blocking these receptors. So to block the transmission of pain experience, either the mu or kappa or delta opioid receptors, it will be blocked by binding that the morphines or the endorphins bind to these receptors, so it will block the pain experience. So there are three different types of families of the peptides or endorphins. The first one is called enkephalins. The other one is endorphins, and then the third one is dynorphins. Enkephalins, endorphins, and dynorphins. But most of the time we just call them endorphins. The opioid receptors, three main classes of opioid receptors, in which that blocking these receptors will result in pain management. Mu receptors, kappa receptors, and delta receptors. Now, the pain threshold and how it's different from the pain tolerance. The pain threshold, which is the lowest intensity of pain a person can recognize, which is the point, which is the lowest intensity at which stimulus is perceived as pain. It may be influenced by genetics. Now, pain tolerance, which is the largest or the greatest intensity of pain a person can endure. So pain tolerance generally decreases with repeated exposure to pain, fatigue, anger, boredom, apprehension, sleep deprivation. All of these are going to decrease patient's tolerance to pain. Other factors may increase patient's tolerance to pain, like alcohol consumption, persistent use of opioid, or chronic use of opioid medications, gnosis, distracting activities, and strong beliefs of faith, spirituality. So the duration of time or the intensity of pain that a person will endure before initiation of overt pain responses, that's pain tolerance. And this is usually influenced by the cultural perceptions, expectations, oral behaviors, gender, physical, and mental health. It will, to some extent, these factors may influence and may change or alter the pain, or at least determine pain tolerance for that specific person. And these factors, again, are the cultural perceptions, expectations, oral behaviors, gender, physical, and mental health. Now, nociceptive pain. So, due to an injury to the tissues, patient may experience somatic or visceral pain. The somatic pain, which is more sharp, localized sensation. Visceral pain is more dull, throbbing, or aching pain. Non-nociceptive, which is neuropathic pain, like peripheral or central neuropathic pain. These are some manifestations of acute pain. Acute versus referred pain. The acute, either somatic or visceral pain. The acute arises from connective tissue, muscle, bone, or skin, in which that it's the alpha A delta fibers. The pain is sharp and well localized. So the C fibers produce dull, aching, and poorly localized pain sensation. The acute visceral pain in the internal organs, like from the major surgery affecting one of the organs, internal organs, that's an acute post-op or after the surgery. That's an acute visceral pain. So pain in the internal organs and abdomen, skeletal, uh, so poorly localized as a result of the lesser number of nociceptors. There are a small number of nociceptors involved. That's why it's poorly localized pain experience, the acute visceral, compared to the acute somatic. The referred pain, which is a pain that is present in area removed or distant from its point of origin. It can be acute or chronic. The area of referred pain is supplied by the same spinal segment as the actual site of pain. So why patients still feel as if they still have they have pain of the same limb that is being amputated or surgically resected or surgically amputated. The impulse from cutaneous and visceral neurons, they converge on the same ascending neuron. So the brain cannot distinguish between the impulse that is coming from cutaneous and the other one that is coming from the visceral neuron. So because of that, the impulses are coming to the same organ from cutaneous skin and from the visceral neurons, two different type of neurons coming to the different sides to the same organ. So when they converge on the same ascending neuron, then the brain cannot distinguish between these two. So that's why the patient will experience what is called the referred pain. Like phantom pain the referred pain is different than the phantom pain. Phantom pain is different because the referred pain, that's when an organ, let's say like patients with cholecystitis, for example, inflammation of the gallbladder, the pain will be referred to the right shoulder and back, the right side of the back. So this type of pain of the right shoulder and the back, that's a referred pain. That's because there are cutaneous and visceral neurons are will converge on the same ascending neuron for the same organ. So the brain cannot distinguish between these two neurons, and that's why the patient will experience referred pain. But phantom pain is different because phantom pain, that's when the patient, when they're still experiencing pain of the limb that has been amputated and surgically removed. Chronic pain, which is related to tissue damage, inflammation, injury of the nervous system, and it may be sudden or develop insidiously. It may be persistent, like lower back pain, or intermittent, like migraine headache, on and off, intermittent. Usually defined as pain that is lasting for 3 to 6 months. And this chronic pain, it will interfere with the activities of daily living, with the ADLs. However, the neuropathic pain, which is most often chronic, which results from the abnormal processing of the sensory information by the peripheral and CNS. And usually it's due to injury to the nerves, burning, shooting, numbing kind of pain, peripheral pain, or central pain. Peripheral, which is like diabetic neuropathy, or central, like phantom limb pain post-amputation. The peripheral pain, which is like diabetic neuropathy, results of trauma or disease or peripheral nerves. So any trauma or disease to affecting the peripheral nerves, like diabetes, for example, that result in peripheral neuropathy. Central neuropathy like phantom pain is usually caused by lesions or dysfunction in the brain or spinal cord, or the phantom limb pain post or status post amputation of the limb. Some differences between peds or pediatric and older adults. Treatment of intractable cancer pain. So when say intractable, means difficult to treat. In other words, it's refractory to traditional classic types of pain management and responsive to traditional pain management agents or protocols. So the treatment of cancer pain, for example, morphine 30 milligrams is an appropriate dose and should be given as an indicator around the clock, like around the clock to give the patient with cancer, to give them the morphine 30 milligrams around the clock, compared to like piperidine and pitazicin. I will go over these medications in a few minutes. So the treatment of intractable cancer pain, radiation, chemo, nerve stimulation, surgical interventions, nerve blocks, and all of these interventions will be covered in Adult Health 2 and 3. So the interruption or the blocking the two main receptors responsible for pain experience are the mu and the kappa receptors. So blocking these, each or both of these receptors will result in different responses. For example, the medication is going to block both mu and kappa, will result in analgesia, decreased GI motility, and sedation. So patients on certain medications that is going to block these two receptors, they expect that this medication is going to result in analgesia and decreased GI motility, so they'll be more prone to develop constipation and sedation. Medications that are strong opioid agonists with high effectiveness would be fentanyl, Duragesic. But because it blocks these two receptors, this will result in constipation, sedation, drowsiness, and dizziness. It's available as transdermal patch, different strengths, 25, 50, and 100 micrograms. Transmits over the patch over 72 hours. We have to change it every 3 days to change the patch. There is nasal spray, and there is also buccal mucosal, and there is also PO tablets. Hydromorphone, Dilaudid. It's available as a PO, also as a sub-Q, an IM, or IV. The mipridine, Demerol. It's not recommended or should be used with caution in the older adult population because the hepatic metabolite could result from the mipridine in older adults. So because of the hepatic dysfunction should not be used. Methadone and then morphine. These are the commonly used drugs from this group. And then from The weaker group, the opioid agonist with moderate effectiveness, like codeine. Codeine, it's a cough suppressant because its effect on or effectiveness to treat patients' pain experience is very minimal, but it has the sub is the effectiveness to stop the cough reflex. So it's so it's going to be used to stop the cough reflex, um, given that its uh, effectiveness to treat pain is very minimal. So it has a moderate effectiveness. So it's a weak effectiveness, or weaker than the previous group. Oxycodone, OxyContin, or Tramadol, or Ultram. Also, these are belong to the pain management groups or classifications, but they are not strong as the previous class, such as fentanyl, hydromorphone, Dilaudid, or methadone, or morphine. And then we have the opioid antagonists. These are the which is the medications going to be prescribed to stop or reverse or to treat patients' opioid overdose, Narcan or naloxone. And from the last group, the most important one is pentazocine or Toluene. So opioids are natural or synthetic morphine-like substances responsible for reducing moderate to severe pain. Opioid receptors are mu, kappa, or delta receptors. But the most important ones for the pain management are the mu and kappa receptors. They're most important among the three for pain management. So what's the difference between opioid agonist drug and the opioid antagonist drug? The opioid agonist that will stimulate the mu and kappa receptors to stop the pain experience, and then the opioid antagonist, it will, instead of stimulating, it will block the mu and kappa receptors, so it will antagonize the opioid agonist. Patients on morphine, for example, we will give them Narcan or naloxone to stop the um, overdose effect of or the toxic effect of the morphine, or in other words, that we can reverse the side effects of morphine, especially or most importantly, the respiratory depression. Analgesics and opioids. And the difference? Well, analgesics are drugs that relieve pain without altering or changing the level of consciousness. However, the opioids are the most effective pain relievers available. So the terminology in terms of opioid or opiate, the opioid was a general term defined as any drug or natural, which is either natural or synthetic, which can would have actions similar to those of morphines. The since the morphine is the prototype drug for that class, the opiate, which is the applied only to the compounds present in the opium, and the dosing schedule. As a rule, we'll say that opioid should be administered on a fixed schedule. So we have a different types of medications that are going to be pure opioid agonist, antagonist opioid, or pure opioid antagonist. The only pure opioid antagonist belongs to this family is the naloxone, in which that we're going to cover it in in this chapter, and naltrexone as well. So can include two here in this group of pure opioid antagonists, there's naloxone and naltrexone. And from the pure opioid, the first group of agonists will be the morphine, codeine, meperidine. An agonist antagonist will have the pentazocine or Talon, the brand name for pentazocine. Um, Opioid narcotic agonists, mechanism of action to interact with specific receptors to relieve moderate to severe pain. Percocet, Oxycontin. So the prototype drug is an opioid agonist, which will interact with mu and kappa receptor sites and used for analgesia and anesthesia as well. Side effects are respiratory depression, sedation, nausea, vomiting. So the morphine, as it binds with both mu and kappa receptor sites to produce profound analgesia, very strong analgesic agent. It causes euphoria, constriction of pupils, and a stimulation of the cardiac muscle. So it is used for symptomatic relief of serious acute and chronic pain after the non-narcotic analgesics have failed. So it's very effective, very strong, and it proved to manage pain levels of moderate and severe pain, and in which that we can use it in case that the other non-narcotic analgesics proven to that's not ineffective to treat this specific moderate or severe pain for that patient. Then we can prescribe the more stringent and more stronger medications like morphine. Given that we know there are some side effects of morphine, serious side effects of morphine, that's why we have to monitor the patient while on morphine. It can be also prescribed as a pre-anesthetic medication and to relieve shortness of breath associated with heart failure and pulmonary edema, and for acute chest pain associated with acute myocardial infarction. So the adverse effects of morphine: restlessness, depression, anxiety, hallucinations, nausea, constipation, dizziness. So the overdose of the morphine or morphine-like medications, it may result in severe respiratory depression or cardiac arrest. So the tolerance develops to the sedative, nausea-producing, and euphoric effect of the drug. The patients may develop physical and psychological dependence, in which that this type of dependence will develop when high doses are taken or prolonged or for a prolonged period of time. So if we prescribe patients takes these medications or morphine over a prolonged period of time, patient may develop the physical and psychological dependence. Sometimes we prescribe the drug as to be given through the epidural, as an epidural pain management or pain epidural drug. So if this drug is morphine is administered as an epidural drug, due to the risk of adverse effects, patients must be observed in um, in a healthcare environment, in other words, fully equipped and staffed environment for at least 24 hours. Like should be under observation for 24 hours with a skilled person, healthcare provider. Because morphine is Schedule 2 controlled substance. So the morphine, since it's a Schedule 2 controlled substance, it should be taken properly according to dispensing instructions. Like, for example, tablets and capsules should be taken whole and not broken or chewed or dissolved or crushed. Alcohol should be avoided with morphine products. Failure to follow these warnings, because that's a black box warning for the morphine. 24-hour, especially for the epidural drug, patient should be under observation for at least 24 hours. Not to be chewed, the tablet or the or capsules have to be broken, chewed, or dissolved, or crushed. So the issue should be, so failure to follow these warnings could result in a fatal respiratory depression. So morphine may intensify or mask the patients who experience or have gallbladder problems. So the morphine may intensify or mask the pain of gallbladder disease. That's because the morphine has the ability to um, result in constricting the biliary tract. So it causes biliary tract spasm of the sphincter of Oddi. So morphine should be avoided in cases of acute or severe asthma, GI obstruction, or severe kidney or liver impairment. So treatment of overdose, the IV administration of naloxone is the specific treatment for morphine overdose, naloxone or Narcan. So the opioids and constipation, narcotics or narcotic analgesics reduce the intestinal mobility, peristalsis. So the intestinal motility will be reduced and lead to constipation. So increasing the fluid and fiber in the diet can help manage this adverse effect. If increased fluid and fiber is not sufficiently effective, then the use of laxative may be considered. The fentanyl patch, before we get into this naloxone, we have to highlight some of the things like, for example, the fentanyl patch. The fentanyl patch, it's a Duragesic or it's a pain medication patch of fentanyl, and it should be changed every 72 hours. However, the full analgesic effect of the fentanyl patch can take up to 24 hours to develop with fentanyl. So the most appropriate or effective um, method to handle these fentanyl patch is to change them every 72 hours. The fentanyl, it has the same adverse effects as other opioids like morphine, including respiratory depression. The morphine and urinary retention. Morphine can cause urinary hesitancy and urinary retention. If bladder distended or inability to void is noted, then the prescriber should be notified. Catheterization or urinary catheterization may be required because there is a urinary retention as a side effect from the morphine. So if we list the actions of morphine, then morphine will result in pain relief, drowsiness, mental clouding, anxiety reduction, sense of well-being. But the main reason for or uh, indication for the morphine would be for pain management, to relieve pain. And it can be administered as an oral, IM, IV, subcutaneous, epidural, intrathecal, because it's not very lipid soluble and it does not cross the blood-brain barrier easily. So what are the clinical manifestations of toxicity to to morphine? So morphine-like medications, toxicity for patients who may develop toxicity to morphine, they will be presented with this classic triad symptoms: coma, pinpoint pupils, respiratory depression, which is the acronym of CPR: coma, pinpoint pupils, respiratory depression. The treatment for that would be this medication, naloxone or Narcan. As some scenarios, patients who are having severe respiratory depression, then they might, sometimes you have to manage these cases with mechanical ventilation, ventilatory support. But the medication to reverse the adverse effects, the toxic effects, uh, these adverse effects, especially the respiratory depression, always naloxone is the answer. So we have to monitor the full vitals before giving the drug, and we will give the drug on a fixed schedule. So we give it to morphine and other medications that are similar to the morphine. So patients who take any of the following medications and develop toxicity to these meds, also they can be treated with naloxone or Narcan. Codeine, such as like not just morphine, but also maybe patients who taking the codeine became develop toxicity or overdose to codeine, hydrocodone, hydromorphone, piperidine, methadone, oxycodone. The answer is always going to be so because naloxone is the antidote for the opioids or opioid toxicity. So just let's highlight the difference between codeine, morphine, and other opioid medications. So codeine, which is similar to morphine in most respects, it produces analgesia, produces sedation, and a euphoria. However, it can also cause respiratory depression, constipation, urinary retention, cough suppression, and meiosis. Meiosis, which is the pupil constriction. And also it can be reversed with naloxone or Narcan. How it's different from the morphine. Codeine, it's not the exact features of morphine. It does have some features are different because the codeine produces less analgesia and respiratory depression than the morphine. So the analgesia and respiratory depression less than morphine. And it has also a lower potential for abuse compared to the morphine. In the liver, about 10% of the codeine will convert to morphine, and it can produce pain and cough suppression. Oxycodone, like OxyContin or Percocet, the analgesic actions equivalent to those of codeine. It's a low, it has a long-acting analgesic effect, and it can be given orally as an IR or CR. IR, which is immediate release, different dosages of the tablet form or capsule. CR, oxycodone, like controlled CR, controlled release, OxyContin, for example. 10 milligrams goes up to 80 milligrams tablets, so different strengths and dosages, tablets or solution. It can be also available as a combination of oxycodone and another medication, like with aspirin or with acetaminophen or with ibuprofen, like the oxycodone with acetaminophen, Tylenol. A drug is called Percocet. So OxyContin and oxycodone, how they are different. The OxyContin releases the oxycodone slowly and continuously over 12 hours. And only needs to be given twice a day. So it may be given, the OxyContin may be given for a chronic or long-term pain, such as cancer-related pain. So it should be considered for patients or those with chronic severe pain. However, the oxycodone, whereas the oxycodone is a short-acting and relief pain for about 4 to 6 hours, so needs to be given 4 to 6 times daily to provide all the pain relief. So that's why oxycodone is usually given for acute pain. So OxyContin, chronic pain, oxycodone, acute pain, like following the surgery or trauma, then we'll give oxycodone. A patient with cancer and cancer-related pain, then they will be on OxyContin. We have other medications like the tramadol, clonidine. Even clonidine, the one we discussed under the alpha receptor agonist, central acting. It has analgesic effect. Clonidine, which is an alpha-2 adrenergic agonist, it has an analgesic effect, so it can be used in combination with opioid analgesics. Adverse effects of clonidine: cardiovascular effect would be severe hypotension, rebound hypertension or bradycardia. So opioid dependence versus the tolerance. So tolerance, we said, is the increased dose, the increased doses needed to obtain same response. So the tolerance, how it's different from the dependence, is that tolerance develops to analgesia, euphoria, and sedation. And also it develops to respiratory depression as well. However, the dependence, which is a state in which the abstinence syndrome will occur if the dependence producing drug is abruptly withdrawn. So it's not exactly the same as an addiction. It's not equated with addiction. It's different um, term or condition than the addiction. So the abstinence syndrome with abrupt discontinuation. So in other words, that the patient, the physical dependence is that the patient, they will experience withdrawal syndrome or withdrawal symptoms from discontinuation of this drug. So the abstinence syndrome would result because of the abrupt discontinuation of this drug. So the patient would have withdrawal symptoms. Now, for the physical dependence to the opioids, it's about 10 hours after the last dose. So patients after the last dose, 10 hours, no morphine or no opioids, they start to develop the initial reaction or symptoms or abstinence syndrome or abrupt physical dependence withdrawal syndrome and symptoms. The initial reaction would be yawning, rhinorrhea, just like drainage from the nose, sweating and perspiration. And it may these are the initial reaction, and then that progress to violent sneezing, weakness, nausea, vomiting, diarrhea, abdominal cramps, bone and muscle pain, muscle spasm, kicking movements, and then last 7 to 10 days if untreated. If patients on morphine for a long time, abrupt discontinuation, develop this physical dependence, and then withdrawal symptoms on syndrome or abstinence syndrome, they may last for a week or 10 days if untreated. So the physical dependence is a state in which the body has adapted to drug exposure in such a way that an abstinence syndrome will result if the drug use is discontinued. And the physical dependence, it will develop during the long-term use of certain drugs such as opioid, alcohol, barbiturates, amphetamines, and the precise nature of the abstinence syndrome is determined by the drug involved. So although the physical dependence is usually associated with narcotics like heroin, morphine, and other opioids, these are not the only dependence inducing drugs. There are other variety, like other drugs, like a variety of other centrally acting drugs like ethanol, barbiturates, amphetamines that can promote dependence. So treatment for opioid dependence, switch from the IV and inhalation forms to the methadone, the oral form. Methadone maintenance, it does not cure but avoids withdrawal symptoms. The treatment may be needed for many months or sometimes even years to treat the physical dependence of the opioids. The new treatment for physical or opioid dependence is the no drugs like the mixed opioid agonist antagonist. There's some sublingual, some transdermal formulations, medications like the uh, Suboxone, buprenorphine, buprenorphine, buprenorphine. That's one of the new medications to treat the opioid dependence. So the opioid-induced neurotoxicity, which will include symptoms like delirium, agitation. So the management will consist of fluid intake like hydration, reducing the dose of the opioid and change to a different opioid like opioid rotation. Non-opioid analgesics like salicylates, um, aspirin, adverse effects, high doses, because of GI distress and bleeding. And that's this GI bleeding or GI distress or upset stomach that, or bleeding, the ulcer disease sometimes result from the chronic use of the aspirin because of the inhibition of the COX enzymes. So it will inhibit the prostaglandin H2 will be inhibited because the prostaglandin is a protective to the GI mucous membrane, especially the stomach mucous membrane or lining. So this protective lining will be destroyed by the aspirin, which will result in a gastric distress and bleeding. So the administration, one of the administration alerts here for the aspirin that it's aspirin as a platelet aggregate inhibitor. So inhibits the platelet aggregation. That's why it can be used as a blood thinner caused by the aspirin. That if that happens, then, for example, if we have a patient is scheduled to have a surgery in 2 weeks, or then we have to plan to hold the drug, hold aspirin as an antiplatelet inhibitor or as a blood thinner should be discontinued at least a week or up to 10 days. So 1 week before or a week before the surgery or scheduled surgery, this drug should be held. So it should be discontinued and held at least 1 week prior to surgery. Otherwise, patient will have bleeding or experience bleeding either intra or post-op. Contraindications, because aspirin increases bleeding time, so it should not be given to patients receiving anticoagulant therapy, such as warfarin sodium, Coumadin, and heparin. Patients on heparin, Coumadin, warfarin sodium should not receive aspirin because that will potentiate the effect of the anti-coagulant therapy, and that will predispose the patient to develop bleeding and hemorrhage. Herbal food interactions, feverfew, garlic, ginger, ginkgo, all may increase the risk of bleeding. So the feverfew, for example, the feverfew is a strong anti-inflammatory agent that's particularly effective at calming redness. It will relieve kind of redness, but studies have shown that it may help reduce damaged skin cells and inflammation, in addition to helping relieve dermatitis and improve the appearance of the skin. But also it may increase the risk of bleeding if given with aspirin. So the overdose, the aspirin, the overdose would be the treatment of the overdose, aspirin overdose may include any of the following. Like, for example, sometimes we use the activated charcoal or gastric lavage to irrigate the stomach and clean it from the aspirin. Laxative, drug therapy for overdose symptoms like when the patient develops dizziness or drowsiness or abdominal pain or seizures. Non-steroidal anti-inflammatory drugs. The first type of drug is the ibuprofen. So, mechanism of action, inhibit the cyclooxygenase enzyme and prevent the formation of prostaglandins. And again, we said that the prostaglandins, like aspirin, it also block the cyclooxygenase and prevent the formation of prostaglandins, which is the protective um, component to the stomach lining. So this runs, and like the aspirin also, it may result in all the NSAIDs, it may result in a stomach upset and the gastritis and destroying the stomach lining. So the case study, we will discuss this in class as one of the case studies in class discussions. Acetaminophen, which is a Tylenol medication, it's a centrally acting non-opioid analgesic to treat fever at the level of the hypothalamus, which will cause the dilatation of peripheral blood vessels and enable the sweating and dissipation of heat. And that's why it's the anti-pyretic. It will lower the and control the and treat fever and hyperthermia. At the same time, also it will relieve pain as a pain management. So it's an analgesic and an antipyretic. So the tramadol or Ultram Also, it's the centrally acting non-opioid analgesic. So the mechanism of action of the tramadol or Ultram, it's a combination of opioid and non-opioid mechanisms. The drug interaction, it may interact with the CNS depressants. And also it's available as in IR and ER formulations. And the case study, we'll be discussing the case study in class. Adjuvant analgesics. The adjuvant analgesics are the drugs that are not classified as analgesic, but they can provide relief for specific types of pain. All of these agents or medications or drugs, they have other primary classifications like antidepressants or anti-seizure drugs or anti-sedative drugs or anti-inflammatory drugs. The use of adjuvant analgesic includes two primary indications. So all of these drugs and medications they have other primary classifications. Like they are antidepressants, but they still have an analgesic effect. Anti-seizure drugs, but also like gabapentin, Neurontin. It's an anti-seizure drug, but it has a significant and effective result in patients with the neuropathic pain, neuropathy. They benefit to a large extent from this Neurontin or gabapentin for diabetic neuropathy or vascular neuropathy, very effective drug. So the use of the adjuvant analgesics, it includes two primary indications. First of all, for pain that is refractory to opioids. Opioids cannot treat the specific type of pain, so the pain is refractory. It's not receptive or it's not responding to these opioids. For this specific type of pain, like intractable cancer pain, these adjuvant analgesics will be great for this intractable cancer pain. The second indication would be for neuropathic pain, neuropathy, like diabetic neuropathy or vascular neuropathy, or phantom pain. So this neuropathic pain, which is caused by damage to the nerve itself, and for being caused by swelling in the central nervous system, which puts pressure on the nerves. So in patients with intractable, for example, we have two different categories or indications, the intractable cancer pain and the neuropathic pain. In patients with intractable cancer pain, the adjuvant analgesics are used in combination with analgesics to enhance the level of pain relief. It is important to understand that these drugs supplement pain relief. They do not substitute for proper dosing of opioid analgesics in patients with severe pain. So the neuropathic pain, which is difficult to control with analgesics. So the most common cause of neuropathic pain is diabetes, but herpes zoster infections, acute trauma, cancer, certain autoimmune conditions can also cause this type of pain. So the neuropathic pain is commonly described as steady, burning, electric kind of shock or pins and needles sensations. So these adjuvant analgesics may be used alone or in combination with the opioids. We can give them together in combination with the opioids. So these adjuvant analgesics are usually dose when we dose them and prescribe them, dose them on a regular schedule as opposed to PRN. They are not usually prescribed as or dosed as a PRN. Usually it's on a regular schedule. You schedule Neurontin, for example, for a patient with diabetic neuropathy. Gabapentin, Neurontin, or gabapentin should be prescribed on a regular schedule. So we have groups of meds here, like anti-seizure drugs. We have benzodiazepines, corticosteroids, local anesthetics, tricyclic antidepressants. All of these are going to alleviate pain. So these, all of these medications has what's called adjuvant use. Headaches and migraines, the tension headache, which is the most common, it's a self-limiting annoyance rather than it's an emergency. So patients, they tolerate the headache, and they tend to cure it with either anti-migraine medications for Tylenol, 650 milligrams, or ibuprofen, or medications that are specific to treat migraine, which includes the caffeine, for example, like acetaminophen, Tylenol with caffeine, because caffeine is a vasoconstrictor. And migraine headache usually, especially tension migraine, usually results from the cerebral blood vessel vasodilatation. So vasoconstriction relieves pain, in which that explains why the coffee would be partially will treat patients' migraine headache attack or episode. So migraine, which is throbbing or pulsating pain, may be preceded by the aura. They can sometimes feel or sense or know that that's impending when they will when they experience the migraine headache attack. Often it's may be precipitated or caused or comes with nausea and vomiting. And the best or most effective treatment for migraine headache will be sumatriptan family. All these medications belong to the triptan, ends with the triptan, as you see here, the top four or five medications, and the bottom one or the lowest in the group or the class is the sumatriptan. And on the top of that one, there is five medications, all of them the suffix, exactly the same suffix, which is triptan. So this is called triptan family, which is the triptan family treats migraine headache. So the most important one, which is the sumatriptan Imitrex. And then we have the ergot alkaloids. So what is the triptan? And then we have the ergotamine. And so what is the triptan? Triptans are the serotonin agonist, and they act by constricting certain intracranial vessels. So there is also ergot alkaloids. So let's finish with the triptan first. So the prototype for triptans are the sumatriptan, Imitrex. It can be given as a PO, intranasal, sub-Q, and this sumatriptan, it treats, or the oral triptan family, it treats the acute migraine headache attack. So it's a serotonin agonist, and it treats the acute migraine headache attacks. It's not for chronic use. It treats the acute migraine headaches. So remember that we said that the migraine headaches, it has patients, or the acute attack of the migraine is preceded usually with the aura. So the individual, the person will sense or know or feel that the impending attack. It's coming kind of in minutes or an hours, but they have that kind of feeling that they may experience the attack shortly. So the sumatriptan, it acts as serotonin agonist, constricting certain intracranial vessels, and that's how why coffee partially can treat migraine headaches, because it results in exact same thing, which is central intracranial blood vessel constriction, because dilatation causes the headache, and then coffee may work with other medications to stop the attack. So the drug is usually given for acute migraine headaches to abort the migraines with or without the aura. So sometimes comes with aura, it sometimes doesn't, but it will be given to stop the migraine headache or abort the migraine headache attack. Adverse effects will be GI upset. Um, Now, sumatriptan should not be, or I'm sorry, should be administered as soon as possible after the migraine is suspected or has begun. Because again, this treatment or the triptans are good for acute treatment or acute migraine headaches, to treat acute migraine headaches. So the sumatriptan or Imitrex should be administered as soon as possible after the migraine is suspected or has begun. It is not effective for long-term prophylaxis of migraine, because we have other medications that must be used for this purpose, which is the long-term prophylaxis of migraine. So sumatriptan belongs to a relatively newer drug or group of anti-migraine drugs called triptans. And again, the triptan, we said it acts by causing the vasoconstriction of cranial arteries. And this vasoconstriction is moderately selective, and it doesn't usually affect the overall blood pressure. It's just very selective to the brain, cerebral blood vessels. So the sumatriptan is the side effects as listed here: some dizziness, drowsiness, and warming sign sensations. However, the contraindications that because of that vasoconstriction, the drug should not be used, or at least if we have to use it, then we'll use it with caution. If the patient has a recent acute myocardial infarction, MI, or patient has a history of angina pectoris, hypertension, or diabetes, that's because of the vasoconstriction of the blood vessels effect or vasoconstriction action. So we have to be careful when we prescribe it to patients with these diagnoses. Now, the sumatriptan also is contraindicated in patients with acute kidney injury or hepatic impairment. Interactions: sumatriptan interacts with several drugs. For example, an increased effect may occur when the drug is taken with the monoamine oxidase, with the MAO inhibitors. So the monoamine oxidase inhibitors and selective serotonin reuptake inhibitors like SSRIs. And SSRIs, medications like the citalopram or escitalopram, Celexa, Lexapro, Prozac, Zoloft, Paxil. We will cover these medications in the mental psych course, and also in Patho Pharm 2 next fall. So the drug interacts with the MAO inhibitors and with this SSRIs. So the further vasoconstriction can occur or result when taken with ergot alkaloid and other triptans. So if this drug is taken with another triptan or with ergot alkaloid, it can result in severe vasoconstriction and significant elevation of blood pressure. So the point here is that the triptans should not be combined with SSRIs because that will result in serotonin syndrome. And serotonin syndrome, patients may, the symptoms or manifestations of serotonin syndrome can range from mild to severe, mild like diarrhea, shivering, and severe like muscle rigidity, fever, seizures. And if untreated, it may result in death. Serotonin syndrome or severe serotonin syndrome can cause death if not treated. So the treatment overdose of the sumatriptan treatment may include drug therapy, if the patient developed any of these symptoms, like generalized weakness, lack of coordination, lacrimation, which is watery eyes and mouth and saliva, tremors, seizures, breathing problems, all of these are signs of toxicity or overdose. Ergot alkaloids, they promote vasoconstriction to treat migraine headaches, attacks. So it's can be given to terminate ongoing migraines. So the regular daily use of ergotamine or ergo alkaloids is likely to cause physical dependence. So that's why patients should limit its use to 1 or 2 times weekly. Patients are instructed to withdraw, to teach them that the withdrawal symptoms may include the withdrawal symptoms from the ergo alkaloids may include headache, nausea, vomiting, restlessness, which are very similar to the migraine syndrome or migraine headache episode. And this can lead to a cycle of dependence and overdose. And symptoms of the overdose may include cold, paleness, numb extremities, or numbness of the extremities, muscle pain, myalgia, and eventual can result in gangrene because of that vasoconstriction. Cold, pale, numb extremities, muscle pain, myalgia, and eventual gangrene. So ergotamine or ergo alkaloid toxicity is the serious toxicity usually caused by acute or chronic overdose of the ingesting or taking these ergotamine medication. And the toxicity results in ischemia, causing the extremities to become cold, pale, numb. So cold, pale, and numb, and these symptoms associated with ergotamine withdrawal may include headache, nausea, and vomiting. And also we'll answer the questions to this case study in class. So last point here is that for severe migraine attack, the patient will likely be given a migraine-specific agent. If that is ineffective, then the opioid analgesic is usually recommended or indicated. And most of the time, the migraine headache attacks or migraine headaches, they often are accompanied by nausea and vomiting. So therefore, anti-emetic, anti-nausea, anti-vomiting, anti-emetic may be indicated as well. So if the beta blockers are given for the migraine attacks, it's given usually used for preventive therapy and not for an acute attack. So this concludes the lecture on pain management.